All right, next up in gastric pathology is the inflammatory diseases of the GI tract. So, a lot of these are chronic diseases. Some of them are autoimmune in nature, so we'll get to those in just a second. Um, the good thing about inflammatory disorders is that they're named for the areas that are inflamed. So, we have gone over gastroenteritis, which is inflammation of the stomach and the intestines. Here we're talking about enteritis, so inflammation of the intestines. So what you're looking at in this picture is a loop of small intestines, and the places where there are arrows, we're looking at sites of inflammation. So we can see some swelling, we see some exudate built up there, and this is a portion of the bowel that has been, or the small intestine, scheduled for resection. So we'll see in some of these disorders that a resection or removal of a piece that's working abnormally is a good way to address some of these disorders. So enteritis in general, it can be acute or chronic, and acute is pretty common, and it's an intestinal infection. So just like gastroenteritis, sometimes people refer to this as food poisoning because it is some really watery diarrhea, and it can involve some associated vomiting as well. It's really common, it's self limiting, it lasts for a short amount of time, again, because these viruses establish themselves in the GI tract, and so once they're removed through the stool, they're not there to infect that host anymore. They can be given to other people and then reinfect that way. You might need antibiotics if it is a bacterial infection. So, if it's an E. coli infection, for example, that makes you pretty sick, that is something treatable with antibiotics. Or you might not need any treatment at all because it is a passing thing. There might need to be some oral rehydration in cases of dehydration. So nausea, vomiting, loose stools, stomach ache. So just a general stomach flu is what people call this. So watery diarrhea is the hallmark. Chronic enteritis are these more long-standing inflammatory conditions like Crohn's disease and ulcerative colitis. They're much more difficult to treat. We're not super sure what causes a lot of their symptoms. We have a pretty good handle on them, but it doesn't mean that they're really easily treatable, and they're definitely not curable at this time. So let's talk about these chronic diseases, the IBDs, inflammatory bowel disease. So there's two that are recognized as being the most common. So we have Crohn's disease here on the left, and then we have ulcerative colitis. So just taking these words apart, this is an eponym, so this is somebody's name, Crohn's disease. Whereas ulcerative colitis, it's involving ulcerations, so holes or sores that may bleed in the colon. So colitis is inflammation of the colon, which is the large intestine. So that's an easy one to remember because it's only going to involve the large colon, and it won't have any small intestine involvement. Because it's ulcerative, there are usually open sores involved in this, which means that there's going to be blood loss, and a lot of the treatments are going to be aimed at healing open ulcers and then preventing them from going on to become more detrimental to the body. Whereas Crohn's disease, you can see both the small and large intestine affected by this. It also involves something we call skip lesions, where there's areas that are really highly inflamed and affected, and then it's almost as if the disease skips an area before there's another area of inflammation. So it's this intermittent, it's every once in a while inflammation. It can affect both the small and large intestines. So we'll start out with Crohn's. This is a typical chronic inflammatory disorder. And in the first couple of chapters of pathology, we learn about chronic inflammation being either nonspecific or granulomatous, meaning that it has the association with the formation of granulomas. Crohn's disease is a type of granulomatous chronic inflammation. So the problem or the main lesion here are going to be a large amount of granulomas, so these altered epithelioid cells turning into these granulomatous areas. So that's one of the hallmarks, is that you're going to see granuloma formation, which are essentially made out of white. That's not going to work on a white background. So granulomas, these scar tissue protrusions, And they are going to lead to mucosal swelling and then eventually erosion of some of that tissue. So it's going to wipe away. And remember, granulomas are these like little igloo things. They contain modified epithelioid cells. They're very tough and they're made of scar tissue. And on the inside are just cells like fighting an infection. Remember, the small intestine's job and the large intestine's job is to absorb products. So instead of having these nice villi or just walls of mucosa for things to go through, like nutrients, in Crohn's disease, there's granulomas. So there's two layers of scar tissue in the way for nutrients to get into the bloodstream where we want it to go. That means that the smooth muscle that lines these different areas is going to have to contract really hard to force absorption of products. That means the muscle is going to get really big, so there will be wall thickening. So that's another hallmark. So marked thickening, and that's of the muscle trying to contract so we can get diffusion of the contents of the small and large intestine into the bloodstream, which lead to swelling and enlargement. So we call this regional enteritis because it involves these skip lesions. So there's certain regions that are affected, and then an area that's skipped, and then more inflammation. Skip area, more inflammation. So regional enteritis. The ileum is very frequently involved, and that's the final part of the small intestine. Remember, the ileocecal valve is what connects the small intestine to the large intestine. So the ileum is right before the large intestine. So that would be right here, the last part of the small intestine. So you'll see the ileum really frequently involved. And this is what these granulomas look like. So here, if somebody had a colonoscopy, so you're looking inside the colon, and what you're seeing are these little granulomas. So again, inside of them are epithelioid cells. Oh no, what happened? Oh no, we're not doing this right now. And this is going to mount a very intense immune response or an inflammatory response as well. So you can see massive amounts of exudate by how shiny this is. So that's all fluid. This is all scar tissue inside. So it's going to be really difficult for nutrients to diffuse into the bloodstream. That means that the contents of the intestines are going to be mainly defecated out, which means that one of the hallmark signs of Crohn's disease is diarrhea. So there's going to be pain with movement, massive movements, really strong contraction of the smooth muscle, and then also diarrhea, which also hurts because you have stool that's moving really quickly to an area that's not ready for it yet. So there's these shooting pains and very watery stool because there's not easy absorption of nutrients or even water over the membrane of the intestines. People can have asymptomatic periods of remission, so there's no symptoms, their disease is kind of laying in this latent state, and it can last weeks to years when the disease is well controlled. They're keeping a food diary, they're staying away from their trigger foods, keeping stress low. There can also be cases of chronic reoccurrence where they get these continual, what are called flares of their disorder. And those can be associated with high levels of stress, both psychological and physiological. And then the immune system breaks down, and then this becomes an out of control inflammatory event with very little diffusion of nutrients into the bloodstream. So you can see weight loss because of that. You're not getting nutrients and calories. Anemia, because you need B12 and folic acid to make red blood cells. And if you have that, then you're not going to, if you have Crohn's disease, you can't absorb those products from the food into the bloodstream because of these massive granulomas. Right now, the treatment kind of focuses on limiting the symptoms of this because there's not a great, we don't know how to cure it. We put a lot of money into trying to figure that out, but basically they use drugs that prevent diarrhea. And that's the best that they can do. But yeah, avoiding trigger foods, things that are really high in fiber would make the intestines work harder than they should have to. The things that you think of as healthy, like oatmeal and raw vegetables, those can be really detrimental to somebody with Crohn's disease. So here is a bit of bowel that was resected. So this was removed because it was creating a lot of problems. We see these red inflamed granulomas, inflammatory exudate. We see some purulent exudate here. So this was an area, just one of these regional areas that was highly inflamed, causing a huge amount of difficulty. So imagine the body trying to force diffusion of nutrients and water over these really large inflamed granuloma pockets of scar tissue and infection. So yeah, in line with limiting the symptoms, if drugs alone can't control the symptoms of Crohn's disease, coupled together with food diaries, food avoidance, they will resect pieces of the intestines out. Okay, and similar in the symptoms, but not in the pathology, is ulcerative colitis. Again, this is not going to involve the small intestine, it's only the colon, inflammation of the colon. Here's a normal colon illustration, here's an ulcerative one. So the mucosal layer is physically broken down, which now allows these deeper layers to be broken down and then can physically bleed. And then those are called ulcers, they're just sores, so ulcerations. So this is the mucosa. That's in caps and in bold because it's really important. The mucosa, so the first layer, the mucosal layer of the large intestine and the rectum. Instead of being regional, this is diffuse. It's this whole area, the colon and the rectum. You don't see thickening of the wall because there's no granulomas. The bowel doesn't have to contract really hard to drive absorption, to try to force food to move its products into the bloodstream. Instead, there is more kind of sluggish rates of bowel movement, so you're not going to see the muscle hypertrophy. And symptoms can be either mild or severe. So the mild, so the things that you would expect would be abdominal pain or discomfort, usually an increase in abdominal sounds. So if you put your stethoscope on the different areas of the tummy, the different quadrants, you would hear increased sounds. When there's constipation, there's decreased sounds. It means nothing's working. A normal amount of bowel sounds just indicates that things are humming along. There can be visible blood or pus in the stool. Diarrhea is very common. Fever, rectal pain, because it involves the rectum, and weight loss. So imagine that when you eat, you've got this low pH stuff going through your stomach to the intestines. And then when it gets here, the pH is higher once it gets to the colon, but it's still more acidic than the body contents. So it's going to burn every time things move through here. So digestion itself is going to be very painful. So people tend to avoid eating, but when they do eat, it's difficult to get diffusion of nutrients and water into the bloodstream. In severe flares of ulcerative colitis, there could be electrolyte imbalances because, again, of losing a lot of water to the diarrhea, hemorrhage, and that's blood leaving the circulation. But in this case, it can be so much bleeding that you see hypovolemic shock, low blood volume, driving a shock response. So this is diagnosed by colonoscopy and then a biopsy while they're exploring with the little scope down there. And there's tons of side effects of ulcerative colitis. It makes you really tired. It limits the ability to engage in physical activity, to eat certain foods. One of the most troubling side effects, though, is that their risk of developing colon cancer is really, really high. So a lot of the treatment is focused on limiting exposure to foods that are considered carcinogenic in general. So one thing that's on here is fired foods. Fired food literally means it's been put on the grill, and you have those little grill marks on it, which make it look delicious, but those grill marks are actually carcinogenic. You're not supposed to eat large amounts of them. And definitely, you're not supposed to eat large amounts or any amounts when there's open sores and damage to the colon already. That can really increase the chances of colon cancer. So small meals so that there's not a huge load going through the colon at any one time. Again, low fiber. Fiber expends a lot of energy. It makes you lose weight. It forms a bulk in your intestines, so we consider it to be healthy. But for someone with an unhealthy colon, it would cause so much damage to the colon that it would sometimes end them up in the emergency room Same thing with raw fruits and vegetables. Those take too much energy on the half of the colon and small intestines to be helpful for people with these chronic disorders. They're recommended to juice those things or consume them in a smoothie or some other soft food. Limit dairy. Again, dairy increases gastric acid secretion. So instead of having a nice stable pH of contents, it becomes more acidic. There's more acid produced. And a lot of the treatment is focused on, again, just treating the symptoms. The primary symptom is diarrhea. So limiting the diarrhea, you can give anti-diarrheal drugs. We're now seeing anti-inflammatory medications being used for these. So things like, what's the drug? The different autoimmune drugs. They've started giving injections with Crohn's disease and UC of those medications, and they are seeing a little bit of improvement with using drugs that we typically use for things like rheumatoid arthritis. Okay, other inflammatory conditions. This is not a chronic one. This happens really once, and then it either goes away or it doesn't, because you're going to have to take out the appendix if it's really inflamed. So the appendix is just a little piece of lymphoid tissue. So cells, kind of like the lymph nodes, cells like the T cells, B cells, natural killer cells, they are in this appendix, which just dangles off of the cecum, so that if anything backs up there, so if there was impacted stool or anything, things would all back up towards the cecum. So if anything gets into the appendix, the idea is that the lymphoid cells would help kill anything before it starts an infection. However, because of its weird location anatomically, it also means that things can get stuck in there physically. And so if bacteria get into the appendix, or pieces of feces and they're unable to leave, then they can stay here and they're trapped in there, and then the appendix starts to swell. So the lumen, the inside opening of the appendix, is really, really small. So if anything obstructs that lumen, then there is the growth of anaerobic bacteria. One of the most common things that can form an obstruction in the bowel in general is called a fecalith. So that's a hardened piece of fecal material. So imagine there's this like golf ball sized or tennis ball size, we can make it bigger, piece of hardened fecal material. You'll see those develop after times when somebody's not using their bowels regularly, like maybe after a surgery, even after giving birth. There's a time where there's an inability to have a bowel movement. So these hardened pieces of feces can develop. So imagine that the colon is still going to keep trying to push everything on because it wants to move it out of the body. So this is going to keep pushing and pushing and pushing, and the muscles are going to keep contracting and contracting. The cells behind those goblet cells, they're going to make more and more mucus to try to lubricate this pathway to move this piece of fecalith out of the way. So the pressure goes up and up and up. Eventually, the veins collapse, there's damage to the mucosal layers, and then it starts to back up to the appendix, and there's a huge amount of swelling and pain. So this is what an inflamed appendix looks like right before it was removed, and it should be 8 to 10 centimeters. And you can see that this one is much, much bigger than that. This is quite a large appendix. We see that it's very inflamed. We see the shiny exudate, we see the redness and inflammation, the increased blood flow. So this is something that's going to have to go. So that's an appendectomy, a removal of the appendix, appendectomy. Because if you do not remove it, then the appendix itself will die. It has the potential of necrosis. And if that's the case, then it can burst, which we know is really, really dangerous when something bursts. The initial pain for appendicitis is just a general aching pain along the midline. So this is the midline of the body. So here's the appendix down here. Here's the deal. These inner organs, they don't have pain receptors. So if I poked you in your appendix, you wouldn't say like, ouch, my appendix. We just don't have a lot of pain receptors there because what do we need them for? Those are way down deep in our body. We need our pain receptors out here. Like, ow, my arm hurts. So you keep your arm away from things, not keep your appendix away from things. So what happens is that we have this lining of the abdominal cavity, and it's called the peritoneum. peritoneum. And this lining lines everything in this abdominal cavity. And it's also really delicate, so it's easy to hurt. So when something starts growing, what it does is put pressure on the peritoneum. And the peritoneum starts to feel inflamed. So whenever there's just a general aching pain along the midline, so it's a mild pain, just like a chronic, like I can't get comfortable, I'm going to shift around in my seat. Um, that means that there is something pressing on the inside of the peritoneum. It could be anything in there. It could be the liver, like you see that in hepatitis when the liver swells. You see that in gastritis. You see that even in the menstrual cycle when there's inflammation of the uterus that presses on the peritoneum, and it leads to just general discomfort along the midline. As this progresses, it becomes more localized, and its pain site is the lower right quadrant. You should remember that forever. Lower right quadrant. If I drew, so just like on this guy, so let's draw our quadrants here. So remember, this is somebody lying on the table. So here's their right side, left side. So lower right quadrant, that's where the appendix is. So lower right quadrant pain, it could always be something else. It could be an ovary that bursts. But when you think lower right quadrant pain, I want you to immediately think, let's check for appendicitis, because that's the hallmark there. Okay, if we went through the other sides, we'll get to this one in a little bit. This is diverticulitis, so lower left. Upper left, that's your pancreas is around that area, and the spleen. And then upper right, that's your liver. And that's where the gallbladder is too. So knowing quadrant pains is just knowing your anatomy. So the appendix is lower right quadrant pain. That's very, very important. Okay, how do you treat appendicitis? Well, you treat it with surgery. The most important thing to know is whether or not that person is in acute abdomen. Acute abdomen is when there is something really swollen pushing on the peritoneum, and that person will have a positive rebound tenderness test. So visit the clinical corner with Dr. Bernosky. Welcome to the clinical corner, everybody. Today we're going to talk about rebound tenderness. Here you see a physician wearing a tie, and he is pressing on the abdomen of a man not wearing a tie. What he is checking for is to see if when he pushes his fingers in this abdomen, if it hurts when he takes those fingers away. So, children, gather round. Remember that when, let's say, this gentleman hurt his elbow, what would he do when he knocked it on something to make it feel better? Ah, yes, he would rub it with his hand. That's a hand, children. It's beautiful. He would rub it with his hand because pressure makes something feel better, like we learned in inflammation. You rub it, you put some pressure on it. So, if there was something swollen in here, here's a thing. Oh dear. When you press on it, it will say, hooray, I feel much better. However, when he takes his fingers away on the rebound, it will scream out in pain and say, oh no, I'm in acute abdomen, help me, I'm dying. Okay, I made her go away because that voice was a little intense right now, but does that make sense? When something hurts, when you push down on it, it feels better for the immediate time. But then when you take your fingers away, it shouldn't hurt that bad if there's no injury. But if there was something under here, you push down on it, pain is temporarily relieved. You let your fingers go, the pain is intensified. That's called rebound tenderness. So pain upon the rebound, the removal of the fingers. So, just to review, when an organ is swollen, it presses against the peritoneum, general aching pain in the midline. You can't really point to it, it's just a generic, general source of pain. When people are in acute abdomen, because pushing on something makes it feel better, putting their knees against their chest or against their tummy or tucking both knees up into them feels better. People with appendicitis, that's your lower right side, they'll keep their right thigh and right hip flexed so that there's something pushing into it. If you try to take their hip or knee away from that side of the body, they'll resist flexion or extension. So they're restless, they're changing positions. It's only comfortable like laying on the stomach or putting their legs up on that side. It's really easily disturbed, but it doesn't become intense until it's very intense organ pain. So it's general, non-specific pain when it's just a little bit of swelling somewhere, but when it's really inflamed, like in that big appendix, you'll see localized pain. Whenever you see localized pain, somebody can point to their lower left quadrant or lower right quadrant and say, it hurts right here. That means that's a pretty intense swelling, okay? So that's what rebound tenderness is. So palpation, sorry, there's an extra it in there. Palpation, so pressing down, verifies that the peritoneum is involved. Fingers briefly apply pressure, then remove. If there's intense pain upon removal, that's a positive rebound tenderness test, and we would say that that patient is in acute abdomen. You'll see that term later. Acute abdomen. All right. You'll definitely see acute abdomen in peritonitis, which is inflammation of the peritoneum. Okay, acute abdomen, like I just mentioned, that is when there is something intense pressing on the peritoneum and it becomes a more localized pain, and they would have a positive rebound tenderness test. When somebody has the syndrome of acute abdomen, there is immediate onset of very high pain. They get very sick. They develop a fever. There's vomiting. They sweat. If it's generalized, it's really serious consequences. So let's say that appendix wasn't removed and it ruptured. Well, that means that all of the contents from the bowel are now liberated to the inside of the abdomen. Do we want things in the bowel, like feces, mixing with everything in the abdomen? No, definitely not. We don't want that happening. And that leads to septic shock, which is just too much vasodilator release causing vessels to dilate, and then blood doesn't get to your organs, doesn't get to your brain, so then you pass out and you don't know the rest. And then when this bacteria gets into the bloodstream, that's called septicemia. That person has gone septic. That's very, very dangerous. You have to go on an IV of antibiotics to remove this. It's actually really great if you like really gross videos. They put people in traction sometimes, and they use this giant saline hose to come and wash everything out from the inside, and then they're admitted and put on a saline and IV antibiotic drip. It's crazy. Because when this happens, it's really, really bad. When there's peritonitis, it's usually going to involve the bacteria from the contents of the bowel. It can also be just different chemical things that inflame that. We'll talk about that later in the dialysis chapter. Remember that when an organ is damaged, so here we have a ruptured appendix. When an organ is damaged and part of it dies, it releases tissue factor. And tissue factor starts the coagulation cascade so that we can seal up that organ with a clot. However, that also means that it's going to activate the fibrin system. So not only will there be a clot forming, there will also be a lot of scar tissue forming. If this forms, so there's a lot of fibrin and this isn't cleared right away, if pus and other exudate isn't cleared, then the body forms an abscess. And an abscess, here, hang on, I don't want to go yet. An abscess is like a cyst. So let's draw an abscess. Here's an abscess. It's just a cyst, essentially, with a capsule. But inside of it is purulent exudate. It's an infection. And so the body will keep, so it's kind of nice that it does that. Instead of having the infection out in the periphery so that the whole body experiences it, it puts the infection inside of this capsule, and that's called an abscess, a pocket of infection. So even if the body, like if this wasn't removed and the body removed this infection, that cyst would always remain. So the purulent exudate would go away, but there would still be a cyst capsule. So the capsule has to be taken out. Generally, you want to remove an abscess so that it doesn't keep filling up. Okay, so in cases like colon perforation, and that the appendix is part of the colon, so something perforates, we can get abscess formation. The worst thing that can happen is not only an abscess, but that abscess perforates an adjacent structure. So here, let's say this sigmoid colon, this is what ruptured, and there was initially an abscess here, so just a pocket of infection, and it grows and it grows. What can happen is that now can open on both sides and end up joining those two structures. Isn't that beautiful? That's called a fistula. A fistula is two organs that have been joined together by fibrosis. So something ruptures, there's tissue factor, there's a lot of fibrin, abscess could develop and then lead to the perforation of two adjacent structures. So imagine this. This is a colonovaginal fistula. So that means that the colon is now connected to the vaginal canal. What that means is that fecal material will escape the vagina. You can see this in males with the colon and the prostate. So females don't have a prostate, but males do. So the prostate surrounds the bladder. So if the colon's attached to the bladder, essentially, or the prostate, doesn't matter which one, they'll end up with air in the bladder, and then when they urinate, there'll be bubbles in the urine, and they'll have a lot of infections. Isn't that great? So that's why it's really important to know how to read a positive rebound tenderness test so that you can prevent things from going this far along and treat it, or if somebody has an initial perforation, treating them the way that you need to so that they don't go on to form an abscess or a fistula. Okay, and now we're on to one of the most common things. You see this in so many adults, and it's diverticulitis. So diverticulitis is the inflammation of diverticulum. What are diverticulum? Diverticulum are little pouches off of the large intestine, and they contain usually just serous fluid or nothing at all. And the development of them is called diverticulosis. Diverticulosis. See that? Osis means development of. Remember that word? Diverticulosis, the development of diverticulum. So that's something that happens with age and with low fiber diets. And they're usually not that bothersome, only when stuff gets trapped in them. So little pouch-like sacs, they protrude from the wall. They can be asymptomatic, meaning they don't do anything, they just sit there, or they can cause intermittent abdominal pain, discomfort, constipation. So this is linked to age and stool volume. So the first thing that you should know is that as you get older, your connective tissue starts to break down. That's just the way things are. So that means it's less likely that so I'll just draw out some intestines for you here. There are these little rings of muscle in the large intestines, and when they contract, okay, so this is it at rest. Now I'll draw it during contraction. They contract so hard that the places where they contract are pretty much all occluded. So this skin all billows out. It's like forced out, and this contracts really hard and then moves things from one piece to another. And if you have a nice healthy bowel, eating things like fiber make that easier on you because it doesn't have to contract so strong, like going lumen to lumen and occluding itself. You would have a lot of food in there, like if you just ate some oatmeal, you wouldn't need to contract so much. So this stays nice and healthy. However, when people get older, it is natural, just through connective tissue breaking down, for some skin to pop out during this. Picture yourself putting your fingers right now around a balloon filled halfway with water. So some of that piece of balloon would come out between your fingers. So in that animation in your mind right now, your fingers wrapping around that half-filled water balloon, those would be the muscles in the colon. So they're wrapping around, and you would make a fist. And then your hand releases. So those little pieces of the balloon that would come between your fingers, those would be like diverticulum. So over time, the more squeezing that happens, the more likely there'll be a permanent damage to the wall. So they can just form as a result of age. Then they're more likely to form, as I was just drawing out, if people don't have large fiber amounts in their diet. So when people eat large amounts of like red meat has no fiber in it, candy has no fiber in it, then you've got this tiny little stool bulk. So the colon has to contract all this way, making it more likely that there's damage and then pockets forming. So even they can eat a steak every day, but have a salad with it. Have something with fiber. It doesn't matter what it is, something with fiber. Have some broccoli. That will reduce the chances of diverticulitis. So the more highly refined carbohydrates people have, like chips, fries, ding-dongs, I don't know what else, Special K, all those kinds of things. No, that has fiber in it. Those have no carbohydrates. Meat has no fiber in it. Sorry, carbs have no fiber. I didn't mean to say carbohydrates. Carbs have lots of carbs in them. Okay, diverticulitis, the quadrant pain, because of the location of the sigmoid colon, is lower left quadrant. So lower right was our appendicitis, lower left is diverticulitis. Again, symptoms of this: fever, diarrhea, constipation. And all this means is that something got stuck in there. These are fine until something gets stuck in there, then they get inflamed, and then it's really difficult for this to contract. It causes a lot of pain when it contracts. These can perforate really easily and bleed into the surrounding abdomen, which causes even more pain. They can become infected and form an abscess. They can also necrose and die. So once these are developed, you have to work with a diet that tries to avoid getting food stuck in here. So nice high fiber diets, but also you want to stay away from things with little seeds in it, like kiwis, strawberries, blueberries, popcorn. All those seeds, they can get stuck in these pouches and then cause them to become inflamed. And then there's a flare, and then you have to take out a portion of the intestines. So they're fine once they form, but you can prevent them from forming by encouraging fiber. Fiber is important. All right, this is what diverticulum look like from the outside. Isn't this nice? Here's the colon. Here's some little pouches. We see them from the outside. But you're not going to be looking at them a lot from the outside unless you're doing a barium scan. When you think of the inside of diverticulitis, I want you to think of Swiss cheese, which is that's not what you see here. You see a colon here with multiple diverticula, but those little pouches now look like little caves you can go in. So the holes look similar to those in Swiss cheese. So on the outside, again, this is what they look like. We see these little berry-shaped outcroppings that just developed because the connective tissue broke down. And then on the inside, we just see the holes that lead to those out pockets. So that's diverticulitis. So lower left quadrant pain. This is what it looks like on a barium enema. So this person was given an enema with barium, which makes it readable on an x-ray. And look how beautiful you can see this. So here's a nice normal sigmoid, and then we see the diverticulum, and they've marked them off right here. This is what I was telling you before. Do you see those rings of muscle there in the colon? That's what they look like. So when they contract, they occlude the whole lumen. So that's how strong they are. Okay, then finally, almost finally, we've got two more things inflammatory wise. Almost. Yep. Okay, we have more diarrhea disorders. First, we have celiac disease, which is an autoimmune disorder. You've probably heard of this before. Celiac disease is when the body thinks that gluten is a pathogen. Gluten is not a pathogen. It is a or it's something that's a part of wheat, and it allows wheat products to rise. So if you've ever made a cake or loaf of bread, if you've ever made a loaf of bread before, you punch the dough down. It's in like a ball like this. You put it in the oven, and then it becomes this big, beautiful loaf of bread. That's gluten that allows it to do that. So it's like this elastic type of protein. And it's not dangerous unless you have this autoimmune disease. So in celiac disease, the body recognizes gluten peptide fragments as a pathogen. So it tags them with antibody. And we know anything tagged in antibody will be destroyed. So where these antibody develop and where there's an immune response is in the small intestine. Remember we talked about the brush border, those villi and microvilli? In celiacs, the main pathology, the main lesion is a flattening of the brush border. There's this huge immune response and it starts to break down these microvilli. So you see pathologically that there's flat brush borders, there's no villi, and villi are there for absorption. So if there's no absorption of products from the lumen into the bloodstream, then all of the things like water and food that will stay in the gut and then come out later through diarrhea. There seems to be a little bit of a genetic basis with celiacs like other autoimmune diseases, which means if you find it in a family member, it's more likely to be present in later family members, so mothers, first order relatives. There's a small breastfeeding link, and the link is that in people with celiacs, the longer they were breastfed, the longer they had symptom-free years. So that's why it says more equals later symptom emergence. So the longer they were breastfed, the longer they were symptom-free. So it didn't discourage them from developing it. It just put off the amount of time they had to live with it. So again, the main lesion here is that the villi are destroyed in this immune cell reaction. It's a product of malabsorption. Common symptoms, abdominal bloating and pain. There is a symptom of this called the wheat belly, which has led to the titles of lots of books and diets, but people immediately become very, very distended in the abdomen, which means you can percuss on it. So just like you would play a drum, you can do percussions on the abdomen to see if it's filled with fluid or air. And tympanic means that it's like a timpani, which is like a drum with the top of it really tight. So when something's tympanic, like, can you hear that? That's like something tympanic, where something like a thud. Oh, that sounds pretty good. I hope you can hear that. Okay, so I'll do it again. Tympanic. This is my table, it's not my stomach. So that usually means there's air in it when it resounds. And then if it thuds like that, that means that there's fluid inside. And you'll see that in things like ascites or in endometrial cancer. Okay, so tympanic distension of the abdomen, chronic diarrhea, vomiting, constipation, pale, foul-smelling stool, and unintentional weight loss. The diagnosis for this is truly an intestinal biopsy. You have to check the cells and see what's going on there. There is a blood test for it, but it's not super reliable. Usually we think of false positives, but in this case you would get a false negative. Like, you don't have the disease, but you actually do. It'd be like an 8-month-old pregnant, or 8-month pregnant, a woman who's 8 months pregnant going into the doctor, taking a pregnancy test and them telling her she's not pregnant. Like, she knows that she is, she's clearly pregnant, but this test, it works that way. It gives these false positive or negative readings. So celiac disorder is a bowel inflammatory disorder different than a food insensitivity. Insensitivities or intolerances, those are non-allergic responses to food. So this generally means that if you are not digesting something, the bacteria in your colon will. So when you digest things, your body breaks it down into fun little component parts that are usable. When bacteria digest things, they do it through a fermentation process. So bacteria, they use fermentation, which means they make gases, lots of gases. So now those gases are filling up this area. And not only is there a lot of flatulence, but there's a lot of stretch, which is going to tell you you have to, empty the bowel really quickly. And there's going to be foul-smelling stool. And when you have to empty the bowel really quickly, that's called diarrhea. So that just means bacteria are doing it. So this is not an allergy. If somebody gets a food allergy testing and they are not positive for the IgE antibody for that allergen, then it's considered an intolerance. And the way that this is diagnosed is by doing an elimination diet, where the person's diet is stripped down to a very few number of foods like rice, water, something else, and then you add things back one at a time to start to see when symptoms occur. So it's a pretty straightforward way of diagnosing it. Let's just pay attention to when these symptoms emerge. So this could be cases like the most common intolerance is lactose intolerance. About a third of the population is lactose intolerant. Um, Lactose intolerance means that there's a lack of the lactase enzyme, which breaks down lactose into glucose and galactose. Without lactase, lactose is digested by bacteria again, which is just going to ferment it and make gas. It could be a lack of absorption, like if people have fructose inability, there is sensitivity to a constituent, which just means that there's a reaction to it. So some people have salicylate sensitivity. The easiest way, if somebody is drinking age, to see if they're salicylate sensitive is to drink a glass of red wine. If they get a headache from it, that usually means they're salicylate sensitive. So that means that there's some sort of physiologic effect that can be linked to the food. And then depending on what type of intolerance it is, symptoms are very varied. So GI irritable bowel, cramping, nausea, diarrhea, constipation, distension, loose stools, and flatulence. And as I mentioned, these are diagnosed by elimination diets. And just finally, I just want to go over diarrhea very quickly. Okay, I want to talk about diarrhea really quickly. So diarrhea is an abnormality in bowel function, and the colon's job, the large bowel's job, is to absorb any extra water that the small intestine hasn't yet absorbed from the contents of the bowel. So the small intestine usually absorbs most of the water. The colon really just has to absorb the rest of it. So the large bowel removes about 900 mils of water and salts a day, so that the feces are nice and firm for expulsion. There's only about 2 to 3 really vigorous muscular contraction sessions per day. They're called mass movements, and they coincide with meals. So the most common time to have your first bowel movement of the day is within about 15 minutes to an hour of your last or your first meal of eating breakfast, because that signals to the colon it's time to engage in a mass movement to empty out a little bit and make some space for the next meals coming in the small intestine, which will then go to the large intestine. And the deal with normal defecation is once the rectum is filled, there are stretch receptors there, and they fill the wall of the rectum, sensory fibers. So once things move from the sigmoid colon, they do this like 90-degree turn to get into the rectum. The sensory nerve fibers come up to the cord, and then they do a local reflex to affect these sphincters, this internal sphincter of the rectum. So that's smooth muscle. So this will help the body not defecate immediately. So this will be tightened up a little bit. And the external anal sphincter is skeletal muscle. It's under conscious control. So at the same time that we have this sensory nerve sending messages to the cord, you can see that there's also going to be something moving upwards in some cases, and that's going to the brain. So that the brain, oh, looks good. Here's the prefrontal cortex, here's like the cerebellum, brainstem, and eventually spinal cord. So you can make a decision about, like, when should I defecate? My body says I have to poop. When should I go? Well, I'll go when it's convenient. And then when it's convenient, that brain can send the message down to the external sphincter to say, okay, it's convenient. You can relax this sphincter now. And this develops by about the time, like 2 to 3 years in normotypical children. Before then, like in babies, there's a message that the rectum is filled and then they poop. That's it. pretty simple. So in adults and kids, there's eventually this override. What diarrhea is instead of a firm feces coming down here and putting slight stretch pressure on the rectum sensory nerve fibers, there is an intense pressure. So it's really unable to be ignored. There's an intense stretch. What that is going to do is remove a lot of the conscious control. Like, so you can't say, class is over in 10 minutes. I think I'll have violent diarrhea in 10 minutes. That is going to increase the urge. The greater the stretch, the greater the urge. So in this case, it's just a lot of stretch, a lot of fecal fluidity. So there's different types of diarrhea. The first is called secretory diarrhea. So we would say diarrhea via secretion. That's when something irritating is eaten, or there's a bacteria, or there's something hanging out in the intestines, and the body decides to squirt all of the water out into the lumen to help, limit that. So water will be absorbed to help dilute that. There's also osmosis. So here we've got water coming in, we're going to dilute it. There's also osmosis, which is when you change the osmotic pressure. So when bacteria build up, so in cases like slow digestion or in like lactase deficiency, there is a high amount of bacteria that builds up. It makes its products, and then the gas encourages water to come in because the osmotic pressure is upset. So then water comes in. So osmotic means because of bacteria. Secretion, it could be bacteria, but it's not slow digestion. Secretion means something irritating is in there. It's making you sick, and then water moves in. Osmosis is slow digestion, bacteria build up, make too much gas, and then water comes in because of the pressure. There's also things that just impair the ability of water to be absorbed from the intestines, just normal things. One is alcohol. So when people drink a lot of alcohol, they can have diarrhea the next day. Antibiotics prevent that. So antibiotics do make people sick. They do cause diarrhea, and that's because they blunt the ability of the body to absorb water from the intestinal contents. And then the final are chemotherapeutic agents or anti-tumor agents. Those cause diarrhea and upset stomach. Same thing. They prevent water from being absorbed. So all of these things are going to allow too much water to be in the intestines. And that's the whole background of diarrhea. Too much water, too much fluidity of the feces, and then increased urge. There are drugs that do that too. And they work by doing those different activities we just mentioned. So there's bulk forming agents, those slow down absorption. Those are all your fiber containing things. They prevent water from being absorbed. There's osmotic or saline agents. So like in a saline enema, for example, we know where sodium goes, water follows. So when you squirt a high amount of sodium into the rectum, water has no choice but to enter the lumen because it's drawn there by osmotic pressure. There's also agents that are just given to induce irritation. So like senna is one of those things. Those irritate the mucosa and cause secretion of water and then subsequent distension of the colon. So those are things that cause quite a bit of like cramping and irritation and pain. Bulk forming, people do get used to them over time, but in the short term, they cause a lot of gas and pain and discomfort. Osmotic or saline agents, those work really quickly. So an enema works within, seconds of being given. So then there's the long-term things, the stool softeners. They don't cause diarrhea like these three things do. They help emulsify fecal fat and mix it with water to make the stool softer and then easier to pass. Who would take laxatives on purpose? So these things can be used to stimulate defecation, and then there's also people who use them because they want to either lose weight or do something else. The first is women with eating disorders. It's very common for people who know how these drugs work and have access to them to abuse them. This is a type of bulimia, laxative-induced bulimia. So rather than vomiting, there's laxatives that are used. Sometimes they're both used, which is very, very dangerous, laxatives and vomiting. Again, you see this in medical personnel because they know how they work. And then there's a really troubling disorder. It's actually a form of child abuse called Munchausen syndrome by proxy. You can click on this if you want to learn a little bit more about it. Um, but Munchausen syndrome by proxy is when somebody abuses their child by making them sick because it makes them more rewarded by getting attention themselves. If you suspect that somebody is poisoning their child or somebody in their care, there is a test that you can do at a hospital looking at levels of certain ions in the stool to see if it is truly diarrhea that is natural or it was diarrhea caused by a drug. You can read more about Munchausen syndrome by proxy. It's a really, really troubling disorder, and people can die from it. And it is going to be your responsibility to report cases like this. When you suspect things like this, you usually see a pretty significant ER history for a variety of different things. So look for repeated visits, and then a lot of unexplained tests. We could talk about that more in person if you'd like. And then we'll finish up with the final inflammatory condition, which is IBS, irritable bowel. It used to be called spastic colon. And irritable bowel is really what you tell people they have when you don't know what else their disorder is. So it can fall into three categories. IBS A, which means it's alternating between constipation and diarrhea. IBS C is constipation mainly, and IBS D is diarrhea mainly. So it's pretty much split into thirds. Um, Generally, IBS is, yeah, when you can't figure out anything else, when you've done CT scans, you've done a barium screen, and you can't find any other distinguishable sign of why they would be having so much diarrhea, cramping, discomfort, sometimes constipation. So you call it IBS. So diarrhea, you'll see an increase in frequency and urge, but there's low stool content with IBS. There's a high amount of mucus, which means that things are moving very quickly, or the body at least is trying to get things to move quickly, so that there's increased intestinal motility. You can also see a loss of peristaltic coordination, and this is referring to when things are moving through the bowel through peristalsis. So if this is some feces moving through, and it's in here, you have a ring of constriction behind it to push it along, and then you'll have an area of dilation in front of it so that the feces can move into an area that's dilated, and then this wave of constriction will go behind that. In IBS, what you see is that there's no time for this wave of dilation, so stool is pushed into an area that's not dilated yet, and it's not ready for it. So that causes those searing pains across the abdomen that people experience when they have like enteritis or gastroenteritis or certain types of diarrhea. That's something that is really common in IBS, and because that's a nervous system that regulates that, that could mean that it's generated by their nervous system, so you might want to do some nervous testing. They also give drugs that are anticholinergic to help with that, because these things run on acetylcholine. Because, I mean, we don't really know much about it. It's just kind of the catch-all so that you can write down something for insurance when you can't figure out what else something is. So the cause is unclear, studies are inconclusive, there's no lifestyle links, no dietary links, very little we know. We do know that flares tend to increase with stress. So some of the treatment just is focused on reducing emotional tension and improving motility through things like exercise and non-specific like biofeedback treatments. So it's an interesting disorder. IBS, the catch-all. All right, so there we are done with those.